Good morning. Welcome to our CU session on series of critical appraisals. So today we will be looking at not new, a different type of a clinical trial design called smart designs, and we have Dr. Namrata who will be giving us an overview on smart designs. What are the subtle differences between a usual parallel arm RCT when compared to a smart design, and we'll also take you through an article which has used this particular design. So I'll hand over to Dr. Namrata for that.
Thank you, sir. Good morning. I'm Namrata. I'll be presenting on adaptive interventions and smart trials today. So the structure of today's talk is to learn what an adaptive intervention is, and then the next is to understand what a smart is, and then is to finally appraise a smart article. So an adaptive intervention is an intervention design that adapts the type, timing, intensity, and or dose or duration of treatment over time depending on the individual's needs. So it is basically a staged intervention with a sequence of decision rules. It is also, adaptive intervention was initially abbreviated as AI, but now we have another AI, so they have changed the name to dynamic treatment regime, which is abbreviated as DTR. So the definition of this might sound complicated, but this is what we do every day in clinical practice. For example, if a 30-year-old school teacher comes to you in OPD with bloating, flatulence and reflux spanning 4 years, he has no abdominal pain, no or altered bowel habit, he has no alarm symptoms, and his physical examination is normal. How do we decide his treatment? We don't just give lifestyle or PPI, right? We have a mental idea as to, okay, this is not, there are no alarm symptoms, why don't we try lifestyle interventions? If lifestyle interventions don't work, we will give PPI. If PPI doesn't work for 6 weeks, we will do a gastroscopy. So this is basically an adaptive intervention, right? So you have a plan at every stage of the patient's clinical scenario. If the patient responds to lifestyle, we will stop there, we will continue lifestyle. If the patient doesn't respond, we will give him PPI. So that is basically the gist of what an adaptive intervention is. So initially you would give lifestyle interventions. If he responds or doesn't respond, you have a plan for each. If he responds, you would continue the same management. If he doesn't respond, you would give him proton pump inhibitors for 6 weeks. If he responds to that, we will probably continue lifestyle interventions and attempt to step down PPIs. If he doesn't respond to that, then we would probably do a gastroscopy. So the idea of an adaptive intervention is, through his clinical course of the disease, a patient can take multiple different paths. One patient can go this way, one patient can go down this pathway, and you have to have a plan for everything. So adaptive interventions, in short, are much like real life clinical decision making. I just wanted to highlight here that adaptive interventions are not equivalent to adaptive trials. In adaptive interventions, you have the entire treatment pathway or your trial pathway mapped out before you start the trial. Whereas in an adaptive trial, it was like the Bayesian statistics that I was talking about that day. The sample size of the trial can change during the trial. You can skip one arm if you feel that there is more benefit in the other arm. You can you can do stopping rules in the middle of the trial based on information you have from the prior of the trial. This is different from an adaptive intervention. Please note that in an adaptive intervention, everything is pre-planned. Nothing changes during the trial. It is just that each patient can vary between arms of the trial. One patient can go down pathway A, one patient can go down pathway B. So in short, an adaptive intervention is a within patient adaptation, whereas an adaptive trial is a between patient adaptation. Now, why is it important to design adaptive interventions? So I just have some scenarios here, like for example, if you have a waxing and waning course of the disease, for example, diabetes. Today a patient comes to you, blood sugars are, HbA1c is 9, you might want to give him insulin and metformin. 3 months later, HbA1c is well controlled, 7, you might step down, right? So in real life clinical decision making, patients flow through different stages of a disease or different intensities of the same disease through their clinical scenario. So you might have to have different plans for each stage, and we don't know what is the optimal sequencing for this plan. That is why adaptive interventions were developed. In an RCT, you would only study metformin versus insulin. But when do you use metformin? When do you combine metformin with insulin? When do you give insulin? Now, The next scenario where we would use an adaptive intervention is optimal sequencing might differ. For example, a patient with early breast cancer, you would want to give them surgery first, and depending on the surgical margins, you will give them chemotherapy. Whereas somebody with advanced breast cancer, you will give them chemotherapy upfront and then go to surgery. So if we know this because there are trials done like this. If we didn't know this, how would we know for an advanced breast cancer patient, we have to start with chemotherapy and then go on to surgery? If there is no widely effective intervention sequence or implementation practice. So this is very prevalent. Most of the adaptive interventions were first conceived in children with mental disorders, because it's a less studied field as to whether behavioral interventions are enough, and there is always a reluctance to give children with mental disorders medication, right? So there was a lot of question as to whether we can try behavioral interventions, should we upfront give medication, should we try some peer support group therapy. So this is how adaptive interventions were conceived. If there are adverse effects or financial considerations of any one part of the treatment, and you want to see whether a less invasive or a more financially affordable treatment is feasible at the first stage. If there are adherence issues, of course, like if you're going to tell people with, say, autism that come for group therapy every day 20 kilometers away from your home, people are obviously not going to, maybe that is the standard of care for autism. This is just an example, but probably people will not adhere to that kind of scenario. So you might want to investigate whether less frequent group therapy is as effective as more frequent individual therapy. And if there is a lot of between or within site in-person or site heterogeneity. So when we come to an adaptive intervention, there are 5 terms that we have to know with regards to an adaptive intervention. This is the lingo that is used when people develop and describe adaptive intervention. So when we read an adaptive intervention trial, we need to know these things. So the first thing is a decision point. The second is a tailoring variable. The third is an intervention option. Fourth are decision rules, and fifth are proximal and distal outcomes. I'll explain these with an example. So this is just a hypothetical example that I made up. So presume we have designed a randomized controlled trial in adult outpatients with diabetes who are obese. And the intervention that you want to give is tailored dietary intervention. Control is standard of care. You are looking for a weight loss of 5 kgs in 18 months. And it is known that obesity with diabetes mellitus leads to worse cardiovascular outcomes than diabetes alone or obesity alone. So the result of this RCT did not reach statistical significance. But there was a lot of population heterogeneity that was noted. For example, 40% of the population lost less than 2 kgs, 18% of the population lost more than 5 kgs after 18 months. So you are wondering that for the same tailored dietary intervention, there seems to be something which is causing some people to lose more weight and some people to lose very little weight. So you want to look at an adaptive intervention to see whether sequencing of different treatments will help this less responsive group. And maybe you can step down treatment for the more responsive group. So if we were to develop an adaptive intervention for this, it would look something like this. So you have a run-in period with a tailored diet program for some amount of time, say for some amount of time, and then you look at whether they are a responder. If they are a responder, you either continue the tailored diet program. If you are a non-responder, you switch to the same tailored diet program plus semaglutide. How do you say that they are a responder? You see whether they have lost 2 kgs or more in the first 6 months of intervention. You are looking to make them lose 5 kilos in 18 months. So at 6 months you say we are going to classify them and do one randomization at 6 months to say whether they are showing signs of early response or whether they are non-responders. Okay, now the decision point here is the point at which you make decisions for the individual patient. So at the start of the trial, you are going to tell them you are going to have tailored diet program. Then at 6 months into the trial, you are going to tell them, let me measure how much weight you have lost. If you have lost less than 2 kilos, you are a non-responder. If you have lost 2 kilos or more, you are a responder. These are the decision points of a adaptive intervention. The next is a tailoring variable. The tailoring variable is used to individualize treatment at each decision point. So for example, in this example, the tailoring variable is the amount of weight loss at 6 months. At this is the threshold at which you're going to call them a responder or a non-responder. Either it can be static like age, baseline risk, or dynamic. For example, you can tell them everybody above 60 after 6 months we are going to give semaglutide. Everyone below 60 we will give them only dietary intervention. Or you can have a dynamic variable like weight. Now some features of tailoring variables is tailoring variables have to be pre-specified and well defined. They should be based on practical, ethical or scientific considerations. So you can't just pick, oh, I want to lose 2 kilos in 6 months. So either the practicality of a tailoring variable is we want to actually save semaglutide for people who are not responding, something costly like semaglutide. Ethical is when you are going through the trial and you're noticing that this cohort of obese diabetic patients are not losing weight, you're probably ethically bound to give them something else. This is more so true in cancer chemotherapy. When a lot of these trials were designed where if one treatment is not working, you can't wait for your endpoint of 18 months to decide to randomize them into another arm. You might have to do a response imaging if they are showing early signs of non-response. And scientific. So is the loss of 2 kgs in 6 months really associated with poorer long-term outcomes? What does the literature say? So your tailoring variable is based on these 3 principles. The next is the intervention option. So that is what you're going to do with this patient if he is a responder or a non-responder. For example, what will the tailored diet program include? Who will administer it? How frequently will it be administered? What dose of semaglutide? What route of semaglutide? All of these have to be pre-specified before you start the adaptive intervention. Now, intervention options are largely classified as step-up intervention options or step-down. In the sense whether you're going to intensify treatment or come down on treatment or continue at the same level. Then there is a decision rule. So the decision point was a time point, okay. Decision rule is at the beginning of the trial you're saying all diabetic obese individuals will receive a tailored diet program. I mean ideally you should expand on this, like what is this tailored diet program. Then the second decision rule is those who lose less than 2 kilos of weight at 6 months will go on to receive a tailored diet program plus semaglutide, whereas those who lose 2 kgs or more will continue the above specified tailored diet program. You are writing your rule or rather your plan for the patient at each point where you are going to change their clinical course. Then proximal and distal outcomes. This is sort of intuitive. So proximal outcomes are if you lose the outcome that you are looking for is loss of 5 kilos of weight in 8 months. Distal outcome, so usually adaptive interventions are motivated by some long-term distal outcome, which is why you are doing such an intensive trial. So probably like in this example, obesity and diabetes, giving semaglutide and diet can help to reduce their cardiovascular risk. So that would be your distal outcome. Now, at this point we have many questions about how to design this intervention better. Even at this point we'll have many questions as to what is a better therapy, how do I sequence this. For example, should we wait and not give any patient any intervention at all? Should we try group dietary therapy instead of tailored dietary therapy, because tailored dietary therapy requires more manpower, more place, more effort, more costs. Should we save only the tailored dietary intervention for the non-responders only? Can we step down the intensity for responders, make it a group dietary intervention? Should we step up the intensity further for responders, add a group exercise therapy? So these are all questions that you could have, and this is why SMARTs were designed. So SMART stands for Sequential Multiple Assessment Randomized Trials. They are designed to, they are a sequence of adaptive interventions with multiple stages of randomization, which are designed to assess efficacy of a set of interventions against another. Okay, so what is a SMART? A SMART is a type of multi-stage factorial randomized trial in which some or all participants are randomized at 2 or more decision points. This is an important point, we will come to it. Whether patient is randomized at the second or later decision point and available treatment options may depend on the patient's response to the prior treatment. So why are SMART designs used? So the crux of the matter is it can answer multiple questions in one trial. For example, if I wanted to know all this information probably from an RCT, I would have had to add many RCTs, right? Like semaglutide versus tailored intervention, group dietary versus tailored dietary intervention, nothing at all versus tailored dietary intervention. Then it also helps you to understand the sequence of treatment. Diet first and then medication, or medication and diet first and then only diet. What baseline measures can be used to make stage 1 treatment decisions? At what point do I need to change the treatment? And what is a good therapy for responders or non-responders? And one very important part that is unique to a SMART trial is it helps to inform about treatment synergy or interactions. For example, in an RCT, you're always evaluating a single drug against a control. You don't know what will happen if you give it with some other drug, right? Like if I give NSAID and opioid for lower back pain, what is going to happen? Nobody knows, because everyone has investigated, say, NSAID against the standard of care and opioid versus the standard of care. The most important thing of a SMART trial is that all or some participants are randomized more than one time. Okay. So this is a busy trial, but so you'd have a group of patients and you give them either treatment A or treatment B. Okay, this is your first point of randomization. Then from treatment A, you are going to use a tailoring variable here to decide who's a responder, who's a non-responder. Responders are given treatment C or D, non-responders are given treatment E or F. Similarly here, responders are given G or H, non-responders are given I or J. It doesn't have to be this intensive. You can decide not to give anything further to the responders. Sorry. Or you can decide to give nothing further to responders here or continue the prior treatment that you were continuing here. But important is that you are randomized more than once. Okay, so I was talking about the adaptive interventions or dynamic treatment regimens that are embedded in this SMART. So any one patient can go through, it is looking at what options one patient can go through. For example, if I have a patient, he might go into treatment arm A, and then if he's a responder, he'll receive C. If he's a non-responder, he'll receive E. Or I can go into treatment A and it can be C and F. Or I can go into treatment A and it can be D and E. Or I can go into treatment A and it can be D and F, right? So this is just the treatment pathways that any single patient can go through. Similarly, these are the combinations for B, okay? Why this is important to understand this is when we are making the sample size of a SMART or the investigating the primary outcome of the SMART, if the adaptive intervention, you are comparing this pathway A into C versus E versus B into G versus I. You need to know the adaptive intervention flow of these two. You're going to compare these two arms, which can also be a aim that is used to inform a SMART. Okay, so I just put the same example that I taken here into the same table. Okay, so we have a group of patients with obesity and diabetes, and then either we are giving them a tailored dietary intervention or we are giving them group diet counseling. Okay, tailored means individual for each person, and group means they are in a group, they are getting dietary intervention. Then you study the responders, those who lose less than 2 kilos in 6 months. This is your second decision point. You are looking at who has lost less than 2 kilos in 6 months. If you have lost less weight, you will either get semaglutide or group exercise in both. If you have lost more weight, you will either get the opposite of what you got. So if you got a tailored dietary intervention, you will get a group diet counseling. If you, or you can continue tailored dietary intervention. If you get group diet counseling, you can either get a tailored dietary intervention or continue group diet counseling. So essentially, if you investigate these two arms, no, it will be like a crossover trial. I just wanted to say that there are trials embedded in a SMART. Okay. Now, one caveat is that randomization is necessary for a SMART, but randomization is not the same principle that we think a randomized trial is for. A randomized trial, a SMART uses randomization as a tool, but an adaptive intervention per se does not require randomization. So in the reason we do randomization in a SMART is so that we can make some causal inferences about treatment effectiveness without having some totally unknown making some totally unknown assumption. But a SMART is not an RCT. For example, from this I can never compare efficacy of semaglutide to efficacy of tailored dietary therapy. So what is not a SMART is if we have questions pertinent only to one stage of trial. The type of trial you use depends on the question you are trying to ask. For example, if I am going to give everybody tailored dietary intervention and only the responders or non-responders I am going to give some different intervention, this is not a SMART. Because my question was if I give dietary intervention to everybody, what should I give to the non-responders? So we have not randomized here in multiple points. We have only randomized one single point. So this is like an RCT. Okay, now this is just an example I took from a paper by Daniel Almiral in 2018. This was studying a weight intervention for a group of people with obesity. So IBT is intensive behavioral therapy and MR is meal replacement, and this is adaptation and counseling. Yeah. So basically R denotes the point of randomization in a SMART. So you have a group of people and then you have given one group you have given behavioral therapy for 5 weeks, one group has a longer behavioral therapy for 10 weeks. This is the first point of randomization. Okay, so this is the decision point. The rule is that you are going to randomize them to short versus long behavioral therapy. Then they looked at responders at the end of week 5 by some amount of weight loss from baseline weight. The responders will continue IBT. The non-responders alone they randomized. They randomized them either to behavioral therapy plus meal replacement or this counseling therapy. Similarly, the people who got the long IBT, they gave them either to continue the behavioral therapy or you augment the IBT, meaning make it more frequent with meal replacement, or you switch to ACT. So these are the dynamic treatment regimes that are embedded in each. For example, you can either get IBT, be a responder and continue down this path, you would be A. If you are getting IBT, non-responder and continuing down the IBT plus meal replacement path, it is B. Similarly, IBT, non-responder at week of N5, you switch to ACT is C. And similarly like that, D, E, F. So these are the pathways down which any patient can go. Now, when you design a SMART, you have to say what your aim is what do you want to find out from this study. So either it can be a main effect aim. Is short duration better than long duration IBT? So what you do, A plus B plus C versus D plus E plus F. Okay. Then the next thing is an embedded adaptive intervention aim. So which of the 4 embedded adaptive interventions leads to the greatest weight loss? For example, A plus B, or is it A plus C, or is it D plus E, or is it D plus F? Responder versus one of the non-response pathways. And then there is optimization aim. Optimization aim is to find out which subgroup, if you find a clinically significant difference, you go back and use Q regression and find out which subgroup the treatment intervention was most likely to be effective in. So again, continuing from this, the sample size of a SMART depends on what your primary aim is. For example, in my example that I had given, your hypothesis 1 can be patients initially randomized to a tailored dietary intervention will have greater weight loss at 18 months than those initially randomized to group dietary counseling. So you are largely like the prior example comparing these two arms, right? Now my hypothesis 2 can be, sorry, this initially is not supposed to be there here. Participants randomized to dietary interventions after either tailored or group diet intervention will have greater loss than the semaglutide or exercise arm. So you will have to pick out the DTRs which say what are the ones that receive group diet counseling after one of these versus the ones that receive semaglutide or exercise after one of these. Then hypothesis 3 might be most versus least intensive adaptive intervention. For example, the least intensive one will be a group diet followed by a group diet. The most intensive will be a tailored diet followed by probably a tailored diet. Or if you are looking at the financial aspect, the most intensive might be something that involves semaglutide. So your sample size depends on what your primary aim from a SMART is. This is just something that I saw online, but I won't be able to explain it a lot because I haven't used it myself. But this is from R. Shiny. This was developed from the University of Michigan. So basically they have 3 basic SMART trial designs, and you tell whether your outcome is continuous or binary. And then you can plug in those values and it will give you a sample size for each of them. Okay, now I'm just briefly touching upon the analysis of SMARTs. So in SMARTs, the principle is that when you have these DTRs, you have to know that we are counting A twice, right? When you compare arms, you should know that A is a common arm for both C and D and E and F. So when you are analyzing finally, you must be able to do this replicated regression, which means that you are double counting the initial arm. So you have to be able to discount that. And the second principle when you are analyzing SMARTs is that the people who, suppose say the responders, there was only one arm after this, and the non-responders there are 2 arms. The non-responders have 1/4 the chance of being randomized into each of the arms, whereas the responder has only has half the chance, because presume that the C and D is just one arm. So you have to double the amount or the weight of a non-responder, because they have only 1/4 of the chance of being in either of the arms. There are also measurements to compare response between each DTR, and there is a principle called Q-learning, which is like a backward regression to find out if a given DTR is effective, which subgroup was it most effective in. So the summary of SMART designs is, it is a multi-stage clinical trial design where at least one set of participants is randomized twice. Subsequent randomization depends on an intermediate outcome, that is a tailoring variable, and it can provide rigorous evidence for adaptive interventions, and it can capture delayed treatment intervention effects like positive or negative synergy, and help to understand which subgroup of patients is most benefited by a singular adaptive intervention. So I'm coming to my trial appraisal now. The case scenario is a 60-year-old man with chronic lower back pain. He has chronic kidney disease as well, secondary to long-term use of analgesics. So imaging reveals multi-level disc disease with spondylolisthesis and no neurological compromise. So you're wondering what optimal non-pharmacological methods can I use in this man with lower back pain. So to inform my decision, there is a trial from the Annals of Internal Medicine published in April of this year, which is looking at effectiveness of non-pharmacological treatments for chronic lower back pain. So this is a sequential multiple assignment randomized trial. So the background for doing this trial was that it is one of the costliest health interventions, that is chronic lower back pain is, and common reasons for a healthcare visit. Multiple pharmacological methods have been studied, multiple non-pharmacological methods have been studied, but no optimal sequencing is known. And we also don't know which subgroup of people is this likely to benefit. There is also little guidance for adapting treatments based on individual response to a singular treatment. So OPTIMIZE was the short form of this trial. So it's a sequential multiple assignment, randomized trial evaluating evidence gaps informing first line care for patients with chronic lower backache. So this is the trial design. So again, like I said, this R means this is the first point of randomization. There are patients who are randomized with chronic lower back pain. Stage 1, you decided to randomize them into physical therapy or cognitive behavioral therapy. Then there is a 10-week assessment period. This is your second point, decision point, where you have randomized them into responders or non-responders. So responders get 2 more of whatever they were getting in the first stage. They were receiving physical therapy, they get 2 more physical therapy sessions. If they were receiving cognitive behavioral therapy, they get 2 more cognitive behavioral therapy sessions. If you are a non-responder, you either switch to the opposite treatment. You are randomized. If you got physical therapy first, you switch to cognitive behavioral therapy or mindfulness. If you got CBT first, you switch to physical therapy or mindfulness. Follow-up was done at 1 year. So before we jump into the appraisal of the trial, I just wanted to look at the components of an adaptive intervention. So where will the decision points be in this trial? One will be here at the start of the trial, and the second one will be here when you are randomizing them the second time. Now what are the tailoring variables here? At this point we said that 50% or greater improvement in, this is an Oswestry Disability Index, okay, it's abbreviated as ODI. It's a disability index for lower back pain that has multiple questions about sleeping, ability to do daily activities, driving, etc. So they said that if you have 50% or greater improvement from baseline ODI score, you are considered a responder. If less than 50%, you are considered a non-responder. So this is the tailoring variable used at decision point 2. Now, what were the components of therapy they were offering? So in cognitive behavioral therapy, they gave pain, neuroscience education, activity pacing, goal setting, identifying, reframing, negative cognitions, pain coping strategies, journaling, assertive communication, all these things they did. And physical therapy, they had delivered by a trained physiotherapist, involved evidence-based protocol of education, exercise, manual therapy. I'm not going to expand on this. Mindfulness is meditation and breath and body sensations, regulating negative emotions associated with back pain. So these are the things they gave. Now what are our decision rules? So the first decision rule is at the first decision point. Adults with chronic lower back pain will be randomized to receive either CBT or PT for 10 weeks. At the end of 10 weeks, you calculate this Oswestry Disability Index. And if there is a 50% or greater improvement from baseline, you would classify the patient as a responder, and they will undergo 2 additional stages, 2 additional sessions of their first stage treatment. However, if the patient is a non-responder, they will be randomized again to receive either mindfulness or the opposite of the first therapy that they got. What was the proximal outcome they were looking at? They were looking at co-primary outcomes of functionality and pain score for stage 1 interventions at 10 weeks and stage 2 interventions at 52 weeks. So they were looking at ODI, this Oswestry disability score, and pain score for the stage 1 10-week intervention at the 10-week mark, and then they looked again at, after they did the stage 2 intervention, they studied these 2 indices again at 52 weeks. So because the flow is similar to a randomized control trial, but it is not a randomized control trial. I am using CASP to appraise this. So did the study address a clearly formulated research question? Yes. So the PICO statement was, participants were adults with chronic lower backache. Intervention was, this is 10 weeks of PT or CBT. Non-responders were randomly assigned again to another remnant of, to complete 1 year of stage 2 treatment. The control is nothing. So SMARTs don't have a control arm. That's why I said a SMART is not an RCT. A SMART has multiple adaptive intervention arms. It has no control. So you are not evaluating any one treatment against another treatment. You are just evaluating efficacy of one adaptive intervention versus efficacy of another. But it is not to say that one is better than another. Co-primary outcomes were measured with this ODI or pain intensity at stage 1 at 10 weeks and stage 2 at 52 weeks, and timeline was either 10 weeks or 52 weeks. This is just something called MOST I wanted to highlight here. This is the full form is multi-phase optimization strategy. So this is just to understand how you study a intervention, right? So there is a preparation phase where you read what interventions are useful where, and you do pilot studies. Then you have the optimization phase, where that is where things like factorial designs and SMARTs are useful. You are looking at how can I sequence the given interventions that I have. And finally is the evaluation phase. This is where an RCT is used. Once you have multiple pathways that work for a patient, you will compare that pathway against the existing gold standard pathway. So, was the assignment of participants to the intervention randomized? Yes, they did a computer generated block randomization using REDCap, and stage 1 randomization was stratified by site, stage 2 by site and stage 1 assessment. Were all participants who entered the study accounted for its conclusion? No, they were not. So, this is the consort diagram for this study. Because the flow is similar to an RCT, they will report a consort diagram in SMARTS as well. I will go through this slowly because it is a lot of information. So, initially they identified patients with lower back pain, so that was some 15,000. Out of that, some 6,000 they excluded for multiple reasons. Yeah, they declined to be screened, sorry, and then they excluded the remaining 6,412. Then eligible for enrollment was 1,229. Now, out of this 461 again declined to participate, so 768 consented. After this, 17 people did not complete baseline assessment, so they randomized 751. Out of the 751, they found out that 2 were falsely included in the study. They had some reasons for exclusion. So, now they assigned 749 in total to either CBT arm or the PT arm. Okay. Now, what they have done is, they have looked at who started treatment, who came for more than 4 sessions, who withdrew, who missed 10-week assessment. So, finally, people who attended more than 4 sessions and completed 10-week assessment only have gone on to the next stage. So, that is only 280 out of 375, that is 74% of the people. Now, similarly, in this PT arm, there were 374 people. Same thing, they looked at who started, who went for more than 4 sessions, who missed the 10-week assessment. Finally, they had only 296 people, which is 79% of the people. So, totally out of 749, say, 576 only have completed their 10-week assessment. Then they have randomized 280 and 296. So, 280 they have randomized into not randomized, they have applied this ODI and then found out who is a responder and non-responder. Again, this 296 they have applied the ODI and pain score and found out who is a responder and non-responder. Now, they took 242 non-responders in this arm and 223 non-responders in this arm, and then they randomized them again. Okay. So, what happened to some people here, I am not sure. Like from this 242 it became 219. There is no reason as to what happened here. Again, this also, this 223 became 204. No, sir. Then they randomly assigned these people. So, these people got CBT initially, so they got PT now, and the other arm was mindfulness. Now, this arm got PT initially, so they got CBT now, and the other arm was mindfulness. Then we can skip this part of 26-week follow-up. We will go to the 52-week follow-up. So, 52-week follow-up, they took responders and those who completed everything here, and they came up with 245 people. So, that is 245 out of 280, that is 87%. And here they took people who finished everything at 52 weeks and the responders. So, that is 275. So, that is 93% of the people.
We have about 20 plus 20 patients missing in the group. That's the entire thing out of 750. That's like about 6% who are not accounted for. We really need to penalize the study for this being, patients are not accounted for.
So that loss to follow up in RCT previously people used to say less than 10% is fine, more than 10% is not fine. But that's not true. Suppose the outcome of interest happened in 2% in one arm and 3% in another arm, then even 1% loss to follow up is significant, because that 1% loss to follow up could have changed the outcome. Here I don't know the percentage of outcome in the end. If the percentage of outcome is like 30% in one arm, 40% in another arm, then maybe 4 or 5% weight loss to follow up in each arm is all right. We can do a sensitivity analysis, what would have happened if those people had good or bad. So it all depends on the number of people finally you have the outcome. 6 is less than the imaginary 10% which people somebody decided less than 10 is okay. Other people argue that if you follow up 1000 people with backache for 52 weeks, in normal course of clinical medicine, at least 6% won't come back to you at the end of 1 year. So this 6% is acceptable from a clinical care standpoint. So it's not, if like 50% were lost to follow up, then you say, oh, something's up. So 6% seems reasonable from a clinical care standpoint, but you will have to see the final outcome and decide whether that overall 6 to 7% made a difference. We'll have to see as a company.
It's a difference in pain score only. Also, there was a loss to, I mean, there was missing data here also. This is. I mean, patient didn't complete. Yeah.
That all missing data is a problem. This is the study's problem. So you have to, for continuous data, you have to. So the question was, what happens if missing data are yes or no? Then you can impute what would have happened if it was yes, what would have happened if missing is no. But if the missing data is a continuous variable, again you have to make some sort of assumption. There are many methods of doing that. And do a sensitivity analysis. What if it was so much? What if it's so much?
Analysis was not intention to treat. They have taken. They have not included the people who are missing. They have done an imputation analysis for missing data, but I thought there was some between arm difference as well. So whether imputation was the right, I mean imputation okay, but should we have used some other methods was my question, because there was some 5% difference between these two arms, and then there was some difference here, and finally it was, they were saying PT arm will be better. So they had more data on the PT arm also, because I thought like, because the result was finally driven by that, could they have used something else? The next section is the study methodologically sound? So were patients blind to the intervention given? They were not. Of note, outcome was subjective and patient reported. It was an appropriate outcome in this scenario. For chronic lower back pain, disability and pain score are the most important patient-centric outcomes that you can consider. Also, I'm not sure whether it's fully possible to mask patients who are getting cognitive behavioral therapy versus physiotherapy. Like you might have to do some sham physiotherapy and sham cognitive behavioral therapy. Might be difficult to do actually in a large scale real world trial. Were investigators blind to the intervention that they were given? Yes, they were. And outcome assessors were also blinded. Were the study groups similar at the start of the randomized control trial? So this is the baseline characteristics at stage 1. So they had looked at a lot of things, including whether they are insured or not insured, because they felt like the seeking health for chronic conditions depends on whether you have the money to seek health for it or not. So they largely baseline characteristics were well matched. I'm just going to stop for a minute so that everyone can look at the. I didn't find any major differences between arms in the baseline characteristics.
I thought I should answer this about imputation. Just go back to that previous slide. So what people usually do is, they do something called multiple imputation. That means there are, statisticians will know, there are 7 or 8 different techniques of imputation. And each time you do one imputation, it's like a different data set. And then you see, like, you do the analysis using different data sets, meaning one imputation technique, another imputation, until you see whether the analysis remains stable. So there is one article called Rubin's rule or something, like, which describes how multiple imputation should be done, and then everybody seems to quote this article, Rubin's rule, or that. So there is a technique called multiple imputation, which is you use different techniques, and finally you say, yes, this imputation seems to be correct or wrong. Like, so you can't, but there are lots of laws to follow up, then whatever technique you do, you have to be a bit careful about that.
This is a continuation of the baseline characteristics, again well matched, same table, the second half of it, and they have reported in their supplementary baseline characteristics for the second stage also. So we would be looking at columns 1, 3 and 4, again all well matched. So I would say randomization worked here. Apart from the experimental intervention, did each study group receive the same level of care? So in a SMART, this concept doesn't actually exist because you are actually comparing different interventions. Your aim is to compare different interventions. So you're not looking as to whether everybody got the same treatment. What are the results? So were the effects of the intervention reported comprehensively? So yes. Was a power calculation undertaken. So sample size of 748 is what they calculated and they got 749 to detect a mean difference of 3 points for the this disability index and 0.62 points for pain in stage 1 treatment comparisons with a 75% retention. That means 25% loss to follow up. I could not understand why exactly they took these two numbers as their points, because they have mentioned that minimum clinical difference that you should have is 6 points for the ODI and 2 points for the pain score. So why did they take such a low difference is doubtful. Okay.
Sample size calculation for this trial, is it from back to front? It's like, okay, you do the second randomization, you calculate sample size for that, and then you
have enough number for both.
that's what. So do we start from back? Do you have?
But then I'll make a difference.
Okay.
Both ways you will have enough number of patients. If you don't start off enough patients, you won't end up with enough patients. So you can do it either way. You must make sure that if you don't have enough number for stage 1, you will not have enough.
Yeah, definitely. Yeah.
But you can do it either way.
Also, they have mentioned that they have decreased sample size due to COVID-19. So when this trial was being done, started in 2019 and 2020, there were COVID-19 restrictions that were in place. So they calculated a decrease from 945 to 748. But to inform this decision, because their primary endpoint was, one of the primary endpoints was to look at this much difference in stage 1 treatment, right? So for that 748 patients were enough. So they got 749. So they said that they had completed their sample size. What outcomes were measured and were they clearly specified? Yes, outcomes measured were difference in ODI, the disability index and pain score at 10 and 52 weeks. And how were results expressed? Results were expressed as a difference in mean disability index and pain score from baseline to the 2 given time points. Results were reported for each subgroup, for each outcome in each study group, and there was missing data. I thought there was missing follow-up between arms, and there was. They have also mentioned that there is some bias because of differential dropout rates. This is the same picture that I had put earlier. So they used this log binomial regression model and modified Poisson model, and they have reported p-values. So this is their stage 1 outcome. So the first thing that we have to look at is Oswestry disability index. So we are looking at 10 and 52 weeks. So they have not done for the unadjusted one. They have done this imputation analysis and done an adjusted change in the ODI. And they have said that after 10 weeks, there was an 8.8 decrease in this disability index.
The 52 week is not the stage 1 intervention, only
After the stage 2 intervention, correct. They have given reported values for everything, but stage 1 intervention was measured at 10 weeks. So here they say that there is a 8.8 decrease decrease in this disability score after 10 weeks of PT, and 6.1 point decrease in ODI after 10 weeks of CBT. Just for reference, ODI ranges from 0 to 100. So with 100 being the most disabled. So this is actually probably a very small decrease. Okay.
The difference was significant.
Yeah, the difference was, the p-value was significant. Then pain intensity, at 10 weeks there was a 1.2 decrease in this pain intensity score, which goes from 0 to 10. For the CBT arm, there was a 0.84 decrease. Again, p-value was significant. Now for stage 2 at 52 weeks, there was, we are looking at non-responders to PT in stage 1 and non-responders to CBT in stage 1. So at 52 weeks, with the mindfulness therapy, they had a 7.9 decrease in ODI. They had a 5.4 decrease in the CBT arm. And mindfulness had a 0.49 decrease at 52 weeks in pain intensity and 0.5 in pain intensity for the CBT arm. And similarly for the below table as well. Again here, nothing is statistically significant. So all of these cross 0, so that means there is a point where they can have no difference also. So was the precision estimate of the intervention or treatment effect reported? Yes, confidence intervals were provided. And do the benefits of the experimental intervention outweigh the harms? I thought no.
For the responders one, then they continue on that treatment, no?
Yes.
So is that what the other 52 weeks is, or that result comes here?
No, this one you are asking? All are non-responders. Sorry, Dr. Anna asked whether there were outcomes reported for the responders also. They were looking at only non-responders. Because they were looking at what DTR would we use in a non-responder. Between mindfulness and cognitive therapy after PT, or between mindfulness and PT after cognitive behavioral therapy. Yeah, so I thought the benefit did not outweigh the harm, because there was only one possibly significant, statistically significant, that also with some questionable missing to follow up data. And harms, they said one person got back surgery after behavioral therapy. I'm not sure, I couldn't find how they got back surgery after behavioral therapy. But they have said that it is related to the behavioral therapy. So other than that, sorry, there were no adverse effects that were directly considered related. See, all these adverse effects at stage 2, long-term follow-up, all are unrelated to the physiotherapy or cognitive behavioral therapy. Only this one is probably related to CBT. So what was the size of the intervention or treatment effect? There was a trend towards clinically significant benefit in the stage 1 PT arm as compared to the stage 1 CBT arm. What were the harms or unintended, effects reported? Yes, and cost effectiveness analysis was not undertaken. So finally the last bit is, will the results help us locally? Yes, you can apply this because it can occur anywhere in the world, and disability and pain are important patient-centered outcomes. But would it provide greater value to the people in our care? Probably not, because physical therapy is already a strategy that we use, and cognitive behavioral therapy is not much used and much more labor intensive. So the appraisal summary is that SMART was an appropriate design to use here. The question that they asked was important. Sequencing is already not clear. They used a clear design and variables, good randomization, outcomes were patient-centered. But patients not masked and the outcome being subjective, I don't know if they could have done anything about it. And there was some missing data and loss to follow up. And we were unclear whether imputation would resolve the issue of missingness. So in our case scenario, we would advise physical therapy to our patient. These are my references.